formation of the body cavity, and development of the respiratory system. Actually, folding I had done before of the lateral folding and the cephalocaudal folding. Formation of the body cavity has been already, you've had one lecture by Dr. Babita, but I'm just briefly going to touch upon these two subjects, and then I will be continuing with the respiratory system, right? So now let's see. Let's go on to the next slide. So today we'll, as I told you, the objectives of the class would be folding of the embryo, formation of the intra-embryonic coelom, formation of the body cavities. So from the primitive body cavity, we'll develop the pleural and the pericardial cavity in the thoracic region and the peritoneal cavity in the abdominal region. Then these two are separated by the diaphragm. You've already had this class on development of the diaphragm, and I'll be starting with the respiratory system development. It's a short lecture, the respiratory system development. So we'll be just going one by one in trying to recap of what we have done, because when we are doing embryology after a gap of some days, generally it's not a very easy subject. Students tend to forget what's happening, what are the events taking place. So for that reason, I've just put a few slides as introductory slides, which we keep on repeating. So as I've told you that when fertilization sets in, two components are formed. One is the embryonic component, which is going to form the embryoblast or the embryonic tissue. So this is the part where my cursor is going on, which is going to form the embryo. And the rest, all that you see, the outer trophoblastic layer, these chorionic cavities, the amniotic cavity, they are all going to form the extraembryonic tissue, or the extraembryonic cavitation is this. So in this picture, there are a lot of cavities. So you have to identify each and every cavity. Above the embryoblast, on the dorsal aspect, the cavity that you have is the amniotic cavity. This is the yolk sac, and outside the yolk sac out here, this is the coelomic cavity. And these are the trophoblasts, which are lodging these blood sinusoids, which are going to give rise to the placenta. We've already done all this. So this is just a recap picture. Similarly, so the extraembryonic mesoderm, when it comes, it lines the chorionic cavity, this extraembryonic coelomic cavity, and as it goes on lining it, there is one place here where it forms the connecting stalk, connecting the coelom with these trophoblastic cells. So this is going to form the connecting stalk, which we would call as which we will be forming the umbilical cord, and the two cavities out here will be the yolk sac and the amniotic cavity. So this is the developing embryo. The tail end of the embryo, this is where the primitive streak, so the primitive streak at the caudal region will completely regress. And from this caudal region, you can see it regresses. If it persists, it can form a teratoma, which we call the sacrococcygeal teratoma. And if it is less, then what happens? It forms less of gastrulation, and we can have a condition which is called the sirenomelia, which we have already done that. So it is, look at the yolk sac on the ventral aspect of the developing embryo, the amniotic cavity on the dorsal aspect of the developing embryo. The connection is the connecting stalk, and in this connecting stalk, what do you see? You see that from the yolk sac, a diverticulum is entering this connecting stalk. And what is this? This is the allantois. The allantois later on in adults will form post delivery. In the adults, it forms the urachus attached to the urinary bladder. So that is the allantois gives us an aspect that this is the caudal region of the embryo, and the cranial end, as we go and see this tube which is forming out here on the dorsal aspect of the embryo is the neural tube, and it is dilated in the cranial side, and just on the cranial side out here you can see the developing pericardial cavity. And as the pericardial cavity is developing, that means the heart is also formed. There are a lot of cells which are forming in the wall of the yolk sac. These are called the angioblasts, the angiogenic cells, which are forming here in the wall of the yolk sac, migrating to the placenta, and they will be going into the body systems also. So these are sagittal sections of an embryo at 3 weeks. That's the week where we have formation of the trilaminar disc. The trilaminar disc means we have 3 layers germ disc: the ectoderm, the endoderm, and the mesoderm. Ectoderm, so this is a sagittal midline section. Exactly in the midline, when we take a sagittal section, what do we see? We see one tube, and which is on the dorsal aspect of the developing embryo. You can see this tube, it's a thin tube, and here there is a curvature, it's forming the bends. A cephalocaudal bending has started, and here it is more prominent. And as we go later on to the 4th week, you see that this blue color structure that you see is more cover, it's more like a C, having a cephalic end, which is going to form the head end of the embryo. On the head end of the embryo, and just ventral to it, this cavity out there is going to form the heart or the pericardial cavity. This is the caudal end of the embryo. So now let's now come to the first picture again. This is the yolk sac. So we have yolk sac is lined by endoderm. Between the ectoderm and the endoderm, what would develop? The mesoderm develops. No, mesoderm develops. Not very clear in this picture, but let's see what happens. This yolk sac is now narrowing. At the, it's forming when the baby, or we say the fetus is forming, the C is curving, the endodermal cavity that is there, the yolk sac is now getting incorporated into this embryo. Getting incorporated into the embryo, and if we look at this picture, what you see it has almost come below the neural tube, and a prominent part of this remains outside. We call it the yolk sac, right? And with this you can see a bit of the allantois also. So I'll come to the next picture. So now this gives you a clear picture of the lateral folding. Now let's see. This is a picture showing you the closure of the neural tube, a transfer section. The notochord. The black structure out here is the notochord, inducing the overlying ectoderm to form the neural groove, the neural tube, which would be forming the nervous system, cranially forming the brain, and rest of the part it will form the spinal cord. The overlying ectoderm is going to form the side. This ectoderm is the non-neural ectoderm, is going to form the skin. But what happens wherever there is this neural tube? This tube will separate, and finally the whole of this ectoderm is going to form the skin throughout the embryo. So we have one tube. The endodermal tube is now entering the body cavity. As it is entering, it is narrowing and it forms the gut tube. It is initially attached to the dorsal aspect, and the embryo is now, look at this cavity out here. This is the amniotic cavity. So there were three components of mesoderm out here. In this picture it doesn't show the color scheme, but just close to the midline we have paraxial mesoderm, which is going to give rise to the somites. Adjacent to that is the intermediate mesoderm, and the most lateral part is called the lateral plate mesoderm. Now, most important it is, we have to focus on the lateral plate mesoderm. The cephalocaudal folding has taken place. In the previous picture, you saw how it's forming a C. Now, what happens with the lateral fold? The embryo, I told you, was a simple thin three-layer sheet. Now it is giving a tubular formation by the formation of the neural tube. Now the body wall has to form. That means here, if you look at the embryo, it is open ventrally. The dorsal side has opened up, but the ventral side has not opened up. Now this mesoderm out here on the lateral side is called the lateral plate mesoderm, which divides into two again. One is called the somatic mesoderm, which would go dorsally and go and get attached with the body wall. So the somatic with the ectoderm form the body wall, while the splanchnic layer, I hope all of you are understanding this, will cover the endoderm, intimately comes and covers the endoderm. That's the primitive gut tube, right? While the primitive body cavity is formed between these two layers. Now what happens as it approaches closer, the dorsal side is attached to this gut tube is attached to the dorsal body wall by a mesentery. Ventrally, it also detaches. There is a ventral mesentery, but that's only in the proximal part. This gut tube, which endodermal yolk sac which enters, is going to form the gut tube, and the gut tube has three parts: the foregut, the midgut, and the hindgut. The part which we are seeing out here is the midgut part. The midgut part, foregut part is proximal. So the foregut part has a ventral mesentery from which a layer of muscle would be coming out, which is called the mesenchyme, which is called the septum transversum. I'll be discussing that later on. You would have done it also. So you see that this part is the splanchnoporhyic mesoderm, intraembryonic mesoderm. The splanchnoporhyic mesoderm, while the ones which are going onto the wall are forming the somatopleuric mesoderm, and the C between these two is forming the primitive body cavity. That means now what is happening? The body is formed instead of a flat disc. It became a C, and the C is now closing on the ventral side. This I had showed you before also. I did switch on the video and I showed you how it is happening, and thereby forming a cylindrical structure which it closes in the midline, and we have the lateral folds are complete. The body closure is complete. If it is not complete, what would happen? It will be something like this. All the structures from the body wall from the inside would be coming out, protruding out. Can be. So when the body walls don't fuse, we call it an omphalocele. So we call it a ventral body wall defect. And when this yolk sac comes out, we call it an omphalocele. This we'll be doing again. I've done these with you, but I'm just repeating because we are concentrating on the primitive body wall cavities. Now look at this embryo where you can see these knob-like structures that you see. ये midline है, ये just adjacent to the midline. These, what are these? These are the somites. ठीक है? and the somites would be giving the mesenchymal tissue of the body wall. The lymph ducts would also be coming from that, and this is the yolk sac which has gone inside, the embryo. So we see a tube above a tube. When it is described, this is a tube and this is another tube. So there are two tubes, one on the dorsal side, one on the ventral side in a developing embryo. Now look at this. This is the yolk sac. The yolk sac is going in. As it goes in, it is now forming the entire foregut, the midgut and the hindgut. This would be part which will reduce in size. This, and it will be a component of the connecting stalk. So the connecting stalk is going to form the umbilical cord, which will be having the umbilical vessels, the allantois and the vitelline duct. The vitelline duct, if it persists, it's called a persistent vitalointestinal duct, which we'll be doing when we do the development of the GI tract. But now you have to remember this. And the allantois, where is the allantois connected in the gut? It's connected to the hindgut. It's from the hindgut, it comes out through the connecting stalk. What's the function of allantois? It doesn't have any significant function in the humans, but in birds and all, it's supposed to be an excretory part. So this is around day 25 and this is around day 28. 4 weeks are over. This is now the gut tube has come inside. This is a completely embryo which is on the verge of bending, and at the same time the neural tube is on the verge of closing. It has not yet closed. It closes, that we have discussed, by the anterior and posterior neuropore. The most cranial aspect was the heart, but because of the folding it has come into a ventral position. So this part is called the primitive pericardial cavity, where the heart lodges. But just below this, there are migrations of the myoblasts, which are forming in the ventral mesentery some cells in which is called the septum transversum, and the heart actually sits on the septum transversum. Just below the septum transversum is the liver. That means in the thoracic cavity we have the heart and the lungs. In the abdominal cavity, most of this is related to the liver. So liver, and this is the gut tube which is getting incorporated into the body cavity. As it is getting converted, the proximal part of this tube is called the foregut. It's behind this, so we can't see it. This is the midgut tube and the lower part is the hindgut tube. The part where the foregut and the midgut are forming, it's called the anterior intestinal portal, and between the hindgut and the midgut is called the posterior intestinal portal. So septum is derived from visceral mesoderm surrounding the heart and sits between the thoracic and abdominal cavity, separating it on either side. On either side, there are two canals which are called the pleuropericardial canals. So now let's see the ventral view of the embryo at 24 days to 28 days. So if we take a section at this level, where the pericardial, near the pericardium, you can see this is the heart tube, and just on it, and it is sitting on this part which is called the septum transversum. The section, this is the septum transversum, and you look at this is a, so note the septum transversum at this part. This is the part, right? And you see the yolk sac out here. This is the part which marks the division of the intraembryonic cavity. So the intraembryonic cavity which was formed has to divide into two parts, an upper thoracic part and a lower abdominal part. So the intraembryonic cavity, so this is the intraembryonic cavity, this is the gut tube connected to the posterior body wall by a layer of two layers of mesentery which is called the dorsal mesentery. The ventral mesodermal layer out here would form the, which is part of the splanchnic mesoderm, will form the wall of the gut. And now let's see what is this. This intraembryonic mesoderm cavity is lined by mesoderm, which is called the somatic layer. The inner layer of this mesoderm, they form mesothelium, which is called the, they are serous, and the outer layer of the splanchnic is going to form this visceral layer of the mesoderm. So this is mesoderm. They are also called the mesothelial cells, which resemble endothelial cells of the capillary. They are squamous epithelium, and these, the cavity between the, so there is a cavity between the two which are called the, so we have this intraembryonic coelom. So the dorsally we have two layers, and this is where the both the visceral and the parietal layer are uniting to form the mesentery. When it goes to the dorsal side, it's the dorsal mesentery. When it comes to the ventral side, it's called the ventral mesentery. But as I told you, the ventral mesentery disappears in the lower part, excepting where we have the lesser ementum, we have the septum transversum. Otherwise, it's missing, and this will, it will get much clearer when we do abdomen. The dorsal mesentery, in fact, gives a way, or we say a pathway, for the vessels and nerves to traverse the organs which are present there. So this is the septum transversum in the body cavity, and we have two canals on either side, the pericardial and the peritoneal canals on both the sides. This is called the pericardial and pleural canals. This is the gut tube. This is the gut tube which is on the posterior side, and this is the septum transversum. Sinuses, venuses means out here. This is part of the heart. The venous return of the heart is by sinus venuses. And if you see, there are certain hepatic channels or these liver cords which are invaginating the septum transversum. So the septum transversum is penetrated by these liver cords, so it also gives rise to part of the hepatic channels cords. And if you look at this clearly, now what happens? This is the completely, we have the body cavity, embryonic, the body cavity, and you look at this, on the dorsal surface are the lung buds, and as the lung is forming, it is pushing these two. It is pushing it in such a way that the outer layer of this and the inner layer of the somatic mesoderm and the inner layer of this and the outer layer of the splanchnic mesoderm would come close together to form the pleura. So I'll do that later on, and you can see that this heart also would expand. It will have its own cavity. So they bulge into them as the trachea would be forming, will be dividing into the bronchi, and lung buds would be forming. They would be pushing themselves into this intraembryonic cavity. So in the next pictures, it will become very clear. So these folds that we see out here, we have one fold which is called the pleuric fold, and this fold is called the pericardial fold. So we have the pleural peritoneal folds which are coming closer, and they are also helping in closing the gap between the abdomen and thorax. Now let's go to the next picture. So septum transversum, as I say, it's a mesodermal in origin, migration of the myoblast from the cervical region. So if you remember, the septum transversum is the part on which the heart used to sit. And the heart, where was it initially? It was on the cranial part. In fact, the most cranial aspect of the developing embryo was the heart. And this would sit on the base, which would be giving rise to the septum transversum. At that time, myoblasts from the cervical region have already infiltrated the mesoderm. So the myoblasts which are here are all from the cervical region, which are also carrying their nerve supply, which is the phrenic nerve. We asked this question, and this already Dr. Babita has already taught you about this. So this begins to divide the intraembryonic cavity into an upper thoracic cavity and a lower abdominal cavity, and the division is not complete. Why? Because we have these pleuropericardial canals on both the sides, into which it's only when the lung buds would come, inflate into it like a balloon. If you inflate a balloon, kya hota? It occupies the space in that cavity. So it will come and occupy those spaces. Thereby these canals would reduce in size and the folds would meet to close it. So this is the ventral body cavity. Organs are suspended inside the chambers. As a result, why? In the thoracic cage, this chambers, they give a, look at this, the thoracic cavity. This is the section, transfer section. We'll be showing you these also, the heart and the lungs. Inside, they are lying in the intraembryonic cavity. Now, from the ventral view, this picture I've already shown you. Note the pericardio-peritoneal canals. The lungs grow into these. The lungs is growing into this. This is the ventral aspect, because this is the baby. Actually, the baby is lying in the body like this. It's not like this. It's not lying straight like this. It's actually lying like this. And what do you see? The lungs, when it expands, it's going to complete these. It's going to obliterate the cavity by making a very thin space where the pleura will come and fuse with each other. So they must be sealed to separate the abdomen and thorax. If they're not sealed, what would happen? There'll be structures from the abdomen entering the thoracic cavity. So the intraembryonic cavity, we have already said. In the thoracic cavity, what is there? The pleural cavities, the right and the left pleural cavities. And in the abdominal cavity, what it is? We have all the intestines, and when we do, it's called the peritoneal cavity. So parietal layer lining its wall and visceral layer lining its organs. So every part there are, even in the pleura, in the pericardium, in the peritoneum, it's made of, they are serous membranes, they secrete serous fluid, which prevents friction between the two layers and allows the organs to move with movement, with respiration. They have minimal fluid in them, right? In the thorax, its development takes place in 5 weeks. So now let's see, what do we see? Now this is the part which we are now concerned with, the growth of the lung bud. It comes and pushes, as I told you, and these would get completely filled with the lung cavity. So it's forming the thoracic cavity. So look at this. They are expanding. It's showing this. They are expanding. So much of fluid was here. This intraembryonic cavity on the thoracic region was quite big. Gradually, as it's getting obliterated, what happens? It is increasing in size. The heart chambers, you can see, as it is increasing, what's happening? It's coming and lying. The pleura is the pleural cavity, is the covering of the lungs as the lung buds are growing and occupying the space. We have now two layers of pleura, the parietal pleura, which is on the outside, which is a part of the inner wall of the somatic mesoderm, while the viscera, which is the outer layer of the splanchnic mesoderm. So you can see that. So we have, these are the pleuropericardial folds. So remember this invagination, as the lungs is invaginating into the intra-embryonic cavity, it is also pulling these pleural and pericardial folds along with this. So it is getting enclosed with each other, right? And the separation between the pleura and the pericardium is taking place by this muscular structure, which is the diaphragm. It's a dome-shaped muscle separating the thoracic from the abdomen. The dome is from the abdominal side. On the center of the dome sits the heart. On either side of the dome, we have the right and the left lungs. And what do we see? How is the diaphragm? What are the components which are forming the diaphragm? It's the septum transversum, the central tendon. The central tendon is the part which is connecting it to the pericardium cavity. Pericardium, the fibrous pericardium. The pleuroperitoneal folds, which are, I showed you in the previous pictures, many pictures, how they are coming in. And they are also helping in obliterating the spaces. As a result, also contributing to the formation of the diaphragm. And the posteriorly, we have the esophagus, so the ventral mesentery, the esophageal mesentery, all connection from that also comes. And there are some parts from the body wall also, some myoblasts from the body wall also will be contributing to the outer part of the diaphragm. So when you get a question or what are the components which are forming the diaphragm, you have to enumerate all these: the septum transversum, the central tendon, the pleuroperitoneal folds, the esophageal mesentery, and the body wall. If the diaphragm doesn't develop, what happens? Structures from the abdomen would come and occupy the thorax, because the thorax abdomen has the intestines. They are very bulky. They like to go any place they find a space. They like to herniate through that. So if there is a breach or there's a cavity in the diaphragm, they would love to move to the thoracic cavity. But if they go to the thoracic cavity, what would happen? The lung will have no space for it to inflate. So there will be a condition where there can be agenesis of the lung, because the liver, the intestines, everything has moved up to the thoracic cage. So now with this, we'll begin with the development of the respiratory system. So now let's see how what I'll be doing: the trachea, the lungs, stages of lung development, and anomalies. So this, why I was talking so much about the gut tube when we have to do the respiratory system. We are interested in the respiratory system. And why was I doing gut tube? Because everything, after all the body systems are coming from either ectoderm, endoderm, or mesoderm. Ectoderm is the surface, mesoderm is the muscle, and all the systems are from the endoderm. Intermediate mesoderm, of course, would give rise to the urogenital system. So what happens? This gut tube, as it forms on the ventral aspect of this gut tube. Look at this gut tube. Now it's very clear. You can see the gut tube. Look at this. This is the foregut. We have the midgut, and this is the hinder, right? This part is the neural tube. So we have one tube, this is the gut tube. On top of the other gut tube, we have the neural tube. In between, we have a vascular, we have the vessels also which will be coming and supplying, right? So now let's see from the ventral aspect of this, a bud develops, which is called the respiratory diverticulum. So what happens around 4th week, there is increased retinoic acid and this in the embryo, and this especially on the cranial aspect, and this gives rise to an increase in a transcription factor which is TBX4, and this TBX4 would induce the formation of the respiratory bud on the ventral surface of the foregut. That means respiratory system, what is it coming from? From where is it being derived? It's a derivative of the foregut. Now think about it. Respiratory system is coming from the foregut. You have done trachea? No, you have not done trachea. You have just done pleura and you will be doing lungs. But you know that the trachea would divide into the bronchi, and trachea is a continuation from school, you know. We have nose, we have larynx, we have trachea, right? Larynx is a space where there is a connection between the pharynx. So otherwise, let's come to the next picture and then we will go on to that part which I was trying to tell you. So this is the respiratory diverticulum coming from the ventral surface of the foregut. So if you are asked where does the respiratory bud or diverticulum develop from, it comes from the ventral surface of the foregut. As it comes, it divides and these would be forming the principal bronchus. The proximal distal dilated ends would be forming the lung buds, right? This starts growing caudally, cranially a groaning kata. Cranially where it is present, it is coming in relation to the larynx, the laryngeal swellings. We'll be discussing that this when we do head and neck and with the bronchial arches. But here I want to tell you that the connection between the pharynx and the larynx is persistent at the cranial part where they are forming the laryngeal inlet. Or we call it in the pharynx, we call it the laryngopharynx. So which is made up of certain cartilages from the 4th and the 6th bronchial arches, and this would continue growing caudally into the principal bronchus and they would be dividing. Now look at this. As it is growing caudally, this goes as a diverticulum. So that means there is, and these as they go down, if septum forms and the septum separates the foregut from the trachea. But so we can see this is the trachea, this is the esophagus which would be forming the coming from the foregut. So it separates out. But since they are what they usually come from the same the septum, if it does not separate, then what happens? There is a connection which remains between the esophagus and the trachea. You can see the trachea dividing into the 2 bronchi. So these conditions are called tracheoesophageal defects. Tracheoesophageal defects, they can be many kind of defects. Usually this should be a complete union, a single esophagus coming, separating from the trachea. But what happens out here? It can happen that the proximal part of the foregut, the esophagus, gets atretic. The distal portion of this doesn't separate out. It continues as with the trachea, forming a tracheoesophageal fistula. this kind of baby, if it is born, what would happen? They are born without any problem. But what would happen? As long as when the mother is feeding this baby, it will be vomiting out everything. Nothing would be going to the distal end. So practically the baby would be starving. Now this kind of deformity can happen where these are quite common actually, which can be treated surgically. The trachea, the esophagus, but they do not unite. They do not form a single tube. The upper end is blind, the lower end is blind. So there's no communication between each. Here also same, when the baby would be given a feed, he would be vomiting. Here, what happens? They are communicating, but they are communicating at the junction between the trachea. So what is happening? This is the angle. This is called the carina. So as soon as the baby is given a feed, it will start coughing. The cough reflex would be very badly, and some of them can go into the lungs, leading to infections. This kind of anomaly, if it takes place, the upper part is going to the trachea. Similarly, what will happen? The feed has been given, the baby would be coughing and also going to the lungs. This also same. The upper end and the lower end are not uniting at the same point, they are uniting at different points. There's a gap between the two. So these are all defects when the trachea and the esophagus do not separate completely. So it is required that the trachea and the esophagus have to separate. So what happens? When there is a septum being formed, the septum fuses on the dorsal surface, thereby the esophagus separates out completely from the esophagus. So this is the gut tube, this is the pharynx, the upper part, that means the laryngopharynx. This is the part of the lung bud forming the principal bronchus, and here what happens on the right side, it divides into three. On the left side, it divides into two, thereby indicating two lobes of the left lung and three on the right lung. As it grows, what happens? This is the parietal pleura, and the part of the visceral mesoderm which is closely associated with it is forming the visceral pleura. The one with the body wall is the parietal pleura, which I've already discussed before. But this is what you are trying to see again. तो ये हो गया visceral, ये हो गया parietal. और ये phrenic nerve है. Phrenic nerve coming from the neck, C3, 4, 5, coming and supplying the diaphragm. So visceral pleura, mesoderm of outer surface of the lung, parietal pleura from the inner layer of somatic mesoderm, and the space between them is forming the pleural cavity. Here, lung, what is happening? As the lung is dividing, it is now going into further divisions, and it will divide to form bronchioles. I'll come to this. So, from 5th week to 16th week is a stage which is called the pseudoglandular stage. That means these divisions that they are there, you see, they give an appearance of a gland, but they're not actually a gland. Since they look like a gland, it's called the pseudoglandular phase, in which these dilatations are formed. So it's called the pseudoglandular stage from 5th to, or we say 7th to 17th week, around 4 months. It's the pseudoglandular stage. Then from 17th week to 24th week, these glandular structure canalize. Canals are formed. So it's called the canalicular stage. And then what happens? They would form dilatations which are called saccules. So that is called saccular stage, which will be forming the terminal bronchioles and the respiratory bronchioles. And the final stage of maturation is the alveolar stage, which happens from 28 weeks. Postnatally, it goes in children up to 8 years. That means this is a process which is even growing after birth. So now let's see what happens in the canalicular between 60 to 26 weeks of gestation, and the terminal sac, which is between 26 to week to birth. Till 7 months, bronchioles divide into smaller canalicular phase with more vessels. So what is the function of the lungs? With that, we need a lot of vessels also coming and giving vessels to it for gas exchange. So as they are dividing, the blood vessels also are going to come closer to it. They are going to come closer to it. So as they form the terminal bronchioles, you find a lot of blood vessels are coming closer to it, and by end of 7 months, by 26 to 28 weeks, they are coming closer by establishing the blood gas barrier. So this is the stage where a fetus is viable, can survive if born during this time prematurely. It's very important. If the baby is born when it is premature, usually problem occurs that it cannot breathe. Gas exchange doesn't take place, and if gas exchange doesn't take place, the baby doesn't survive. It's not viable. It's not a viable pregnancy. The last stage we say is the alveolar stage, where the last 2 months this is prenatally, and now look at the blood vessels. They are closely opposing with this. So you find that the terminal part of these, this is the respiratory bronchiole, these are the atrium, these are the alveolar sacs, alveolar ducts, the alveolar sacs, and what do we see with it? We see squamous epithelium lining them. These are called the alveolar cells or the pneumocytes. The pneumocytes have a very important function. Type 1 and type 2 pneumocytes, which are lining them, forming the blood gas barrier where exchange is taking place. So the type 1 cells are the ones where exchange between gas takes place, while the type 2 pneumocytes, they secrete surfactant which lowers the surface tension. It lowers the surface tension, and if when the fetal breathing takes place, it's only when there is lower surface tension that they would be expanding. That induces respiration to begin at birth. So at birth, only 1/3 of the alveoli present at birth are present, and later on, as respiration sets in, alveoli start forming. Alveoli are not formed before that. So the pneumocyte 2 is the one which is forming the surfactant, and the constituent of the surfactant is a phospholipid which is capable of lowering the surface tension between the air and the alveoli interface. So the air and the alveoli interface, you have to have a low surface tension. And type 1 alveolar cells are thin pneumocytes. They surround the capillary and produce inside, and they are the ones which help in the blood gas barrier. Now look at this. These we get fetal autopsies. I had shown you some pictures before. If we try to see this picture, what do we see? Look at this. These are the lungs in the thoracic cavity, the diaphragm. This part you see. This is the liver, the umbilical cord, the heart. The thin structures out here is the lungs. Now look at this. ये heart हो गया. यहाँ पर आपकी thoracic cage दिख रहा. You can see the posterior thoracic cage. Lungs are very, very rudimentary, hypoplastic lung, not developing. This is a patient, this is a fetus of hydrops fetalis, lot of fluid in it. So these are the ones which have fluid in it, so the surface tension, the lungs do not inflate. This is in our department, Dr. Kakeshwar, you knew it was a part of a thesis where we did development of the lung, and you can see how the alveoli are formed. We'll be doing respiratory epithelium, kal hua na aapke saath. So in that you would have seen how alveoli and all look. So these are fetal studies where you can see these are bronchioles, terminal bronchioles. Different kind of stains we've used to show different components, but I just wanted to tell you that we have had some work on development of the lungs. Now, this is a very serious condition which is called the respiratory distress syndrome. So surfactant is the phospholipid is produced after 28 weeks. So premature babies, when they are born, they need help. The air-water interface, that's because of blood, it's not water. The surface tension increases, and with each breath the baby takes, the alveoli fill with fluid and it collapses. So you can see here, this is the normal breathing, while this is a collapsed lung. So they all, like, this is a bunch of grapes which are nice and round. These are shriveled and they lead to death. Initially, it used to be called the hyaline membrane disease because they were they were smooth structures which were seen under microscope, glistening structures. That's why it was called hyaline membrane disease. And this happens when there is a premature and there are certain conditions where the surfactant is not produced. So the anomalies that one sees in respiratory system is respiratory distress syndrome, a lung agenesis where they can be lung doesn't form or doesn't inflate because it can be because of a diaphragmatic hernia where the abdominal cavity are pushing it. In a hydrops fetalis case, the bronchial tree may not divide properly, abnormal division, or it can have ectopic. In fact, instead of having 3 and 2 on the right, 3 on the right, 2 on the left, it can vary in divisions. And ectopic lung means since it's a derivative of the foregut, in esophagus sometimes one can have lung tissue. And sometimes they are cysts develop in the developing lung and they are fluid accumulated. They also lead to a lot of infection, and the babies are always sickly children and they do not even make it because of the sickness. And body cavities, of course you've done it, and I'm just discussing out here the body cavity. And there is one very important fact about this respiratory, what do we say, this phospholipids which are secreted by the pneumocyte tube. So during birth, the baby actually takes its first gulp of air when it is born, and that's the first cry. Before birth, respiratory movements are possible, and they are possible because of the surfactant. And when this is happening, the baby is still in this water environment in the amniotic fluid. So some of the surfactant goes out from the baby's esophagus, from the baby's trachea, we say from the mouth, oral cavity, and goes into the amniotic cavity. In the amniotic cavity, these phospholipids, when they go, they trigger the interleukin 1b in the amniotic fluid, and these are the ones which are responsible for secretions of prostaglandins there, and the prostaglandins are the ones which would be helping in uterine contraction. So when there is respiratory maturation, the labor sets in by this phenomena by which so when the lung is mature enough, says I can breathe, it sends out its messenger through the amniotic cavity, which would be releasing the prostaglandins, and this would be giving rise to the uterine contractions, which are the labor pains. And the labor pain, when it sets in, what will happen will be rupture of the bag of water, which is the amniotic cavity, which we've already discussed when we did the amnion, the chorion and all that. I've already discussed all that with you. So the respiratory movements take place before birth, but respiration takes place after birth. And that is the indication. Otherwise, if we see a lung which is born before birth, in medical legal cases, it's filled with fluid, it will sink. But a baby which is born postnatally would float because it's filled with air. So, with that, we finish today's lecture. And if there are any questions, you can ask me later, or because if anybody wants to say something. Anything? I don't see anything in the chat box. If there are any questions. Okay, let me ask this girl, Amisha. It's easy to go from the first roll numbers. Right, anyway, and I hope you people are following what your teachers are telling you. You are making your diagrams in the practical class that we have allotted time, so that you have your rest of the time to study. Otherwise, you will be just wasting time. So here, whatever time we have, you can do your practicals, you can do your discussions, and all that can be done here. Right? So now I will come back later on when we have more classes. So any problem anyone is having can always inform me. I'm always approachable, or you can ask your CR Gauri to contact me, because she is, and Supreet, your other CR, right? So okay, I'm ending the class.